we're going to be discussing today neutropenic fever. I'm not an ID fellow yet, so this is just for the internists, basically. So the learning objectives for today's lecture, we should be able to, at the end of this lecture, to define a fever, to define what is febrile neutropenia, and understand its urgency in the oncology patients. We should be able to identify which populations are at risk of developing these complications, and we'll review some of the most commonly used chemotherapeutic agents that are known to cause neutropenia. We will also go over some common pathogens, including bacterial, fungi, viral pathogens that can cause infections in neutropenic patients, and we'll also go over antimicrobial management and overall the management of these patients. So I would also like to go a little bit of back and talk of the history of fever, the history of febrile neutropenia, and we should start by presenting this statement. Give me the power to create a fever and I shall cure any illness. This was said by Hippocrates, the ancient Greek. A neutropenic patient would say, if only, right? So these patients are very severely immune compromised. And here we have a picture of Karl Wunderlich. This is a German physician who is actually in the 19th century was the first physician to ever address the issue of what is the normal body temperature. And he did experiments by doing axillary readings of over 25,000 healthy patients who were in the military. And he actually published these results in a paper titled On the Temperature in Disease, a Manual of Medical Thermometry. He said that basically the normal temperature should be around 98.6. And these concepts were prevalent in modern medicine. Like, it is like a little bit unbelievable that it wasn't until the 1990s when a group of physicians from the NIH challenged these concepts and decided to do a large study, and they come up with some findings saying that these parameters that Wunderlich actually published should not be used, and they came up with other parameters about the lower limit of normal and the upper limit of normal, and obviously the most acceptable and the most closely reflection of the core body temperature is a rectal temperature, and we should all know that we should avoid rectal manipulations in neutropenic patients because the risk of creating some mucosal tears and worsening infections. Here we have a Paul Ehrlich. He is a Nobel Prize winning German Jewish physician who worked in the fields of hematology, immunology, and antimicrobial therapy. And he is the first physician who ever described the neutrophils in peripheral smears. And he sort of described the implications of neutrophils in acute inflammation and early infection. And as a side note, he's also the first physician to ever come up with an effective cure for syphilis using arsenic compounds, which I thought it was like a really cool fact about this guy. So here we have a slide with the hematopoietic process. I remember in the multiple myeloma lecture, Michelle went over these slides, so we're not going to spend too much time. We all need to know that the mature neutrophils are produced by bone marrow precursors, and then the total body neutrophil content can be divided conceptually in three compartments: the bone marrow, the blood, and the peripheral tissue. And in the bone marrow, the neutrophils exist in two divisions: the mitotic compartment and the storage compartment. The neutrophils leave the bone marrow and they enter the blood, and they never go back to the bone marrow. Once they're in the blood, they can be found in two other sort of compartments: the marginal compartment and the circulating compartment. Some of the neutrophils do not circulate freely, the ones that are in the marginal compartment, and they are adhered to the vascular surface. And this is about half of the neutrophil population. And once they leave the blood, they enter peripheral tissues in a random manner, and then they perform their basically their actions, either cellular actions or death. And it is known that the lifespan of a neutrophil is around few hours to up to 5 days. So we'll be focusing today on the granulocytes, as I said. So what's the deal with all of these neutrophils? We know that they're the most abundant type of WBC mammals. They're the first responders in acute inflammation. They're the first cell line that migrates to the site of infection. As I said, they have a very short lifespan, and they have basically three methods of activity: phagocytosis, degranulation, and the production of neutrophil extracellular traps, which is a new mechanism recently proposed of the neutrophil actions. And if you're going to talk about neutropenic fever, we should all know that everything started here with this paper. It was a paper published in the 1960s by Bodie. And this is the first paper in the medical literature that correlates the degree of granulocytopenia and the risk for infections in oncologic patients. And they even came up with the number of 1,500 absolute neutrophil count, and below this threshold, patients are at increased risk of infections. So we're going to go on and define some basic concepts. So if we're going to talk about neutropenic fever, we should all have a universal definition of what a fever is. And in the IDSA guidelines, in the American Society of Clinical Oncology, and in the European Society of Medical Oncology, we all know that the fever is a single oral temperature of greater than 38.3 Celsius degrees or 101 Fahrenheit, or a temperature greater than 38 or 100.4 Fahrenheit sustained over a 1 hour period. And then we also have basically the degree of neutropenia, which we all know as neutropenia is defined as an absolute neutrophil count less than 1,500, but then there's mild, moderate, severe, most severe, or profound neutropenia, depending of what the levels are. And below 500 is when we call severe neutropenia, and this level basically dictates most of the actions that we should take on neutropenic patients, and then profound neutropenia has other clinical implications that are also very relevant. There's another concept of functional neutropenia that refers to some hematologic malignancies in which the qualitative defects of impaired phagocytosis basically makes the patient neutropenic, even though the ANC is above the thresholds that we mentioned. But this is a different topic, and for today we will be addressing the neutropenia, which is basically induced by chemotherapeutic agents in oncologic patients. So in the literature, the most recent guidelines published here in the US by the IDSA are a little outdated. They go back to 2010, and then initially they focus on the initial evaluation of these patients, what antibiotics to use, when to do the reassessment of these patients and on their ongoing course, and then what prophylaxis to use. And then in 2014, the American Society of Clinical Oncology published their own guidelines using like the IDSA guidelines as a sort of the most current guidelines at a time. And they also added some information about identification and management of low-risk patients. And then in Europe, most recently in 2016, they published guidelines also focusing a lot in the duration of therapy and the outpatient management of these patients. So if you read the guidelines that are currently available, there's a lot of information that is controversial, and we should be expecting new guidelines coming soon because of a lot of information that is emerging in these days, specifically about the duration of the antibiotic management of these patients. So myelosuppression and neutropenia expected, and is a common major toxicity of systemic chemotherapy. That's a fact. We know that neutropenia increases the risk of infection and is directly correlated to the degree and the duration of the neutropenia. And we know that if you have a solid tumor and then you're receiving chemotherapy, you will develop neutropenia in 10 to 50% of the cases if you have during one or more of your chemotherapeutic cycles. And if you have a liquid malignancy, that number goes as high as 80%. So more than 80% of patients receiving active treatment for liquid tumors will develop neutropenia. And then in these cases, 20 to 30% of febrile episodes have a clinically documented infections, and the most common sites involved are the intestinal tract, the respiratory tract, and the skin. So it means that if a patient is febrile, there's a chance two-thirds of these patients don't have a documented burst of infection. And if you're profoundly neutropenic, if your ANC is less than 100, up to a quarter of these patients will have a bloodstream infection. Here is a table with the distribution of the chemotherapy score linked to the degree of induced neutropenia. I think it is very important, especially here at Mount Sinai West, that we're now dealing with so many cancer patients, that we are familiar with the degree of neutropenia that some of the regimens that these patients are exposed to, and the implications of neutropenia. So there's scores range from 0 to 4, and basically if a drug has a score of 0, like bleomycin, there's basically no risk of neutropenia. And if a drug has a score of 4, like etoposide or paclitaxel, these are known agents that can cause severe neutropenia. So if you have a patient who comes to the hospital and they were recently exposed to these agents, you can go to the literature and be prepared, because these patients are likely going to develop a profound neutropenia, and then you can be prepared on the duration, how long you should expect of these patients being neutropenic and when they're able to recover their counts. So for the neutropenic fever, obviously infectious, as I said, is the highest risk, and we see here a trend that goes as back as the 1970s, and the evolution of the organisms that are typically involved in the infectious causes in these neutropenic patients. And we see that in the 1970s, 1980s, the gram-negatives were like the predominant pathogens. And in the mid-1980s, early 1990s, we started to see a rise in the prevalence of gram-positives. And initially, we were not sure why is this happening. Why is like suddenly these pathogens like changing so dramatically? And we know that now we know that it's because of the more aggressive chemotherapeutic agents that we're using. Patients are more likely to develop severe mucositis. We're also treating older patients and more aggressively with indwelling catheters. So this also represents another risk factor for developing gram-positive infections. We're doing a better job in prophylacting these patients when they become neutropenic, and the most commonly agents are more targeted towards gram-negatives, like the quinolones. And also, it is known that antacids, PPIs, have a very great impact on the prevalence of gram-positives. We are decreasing the acidity in the gastric contents and the pH. So there's more likelihood of developing normal flora infections, and their predominant normal flora infections are gram-positives in the skin and in the mouth, gram-positive anaerobes specifically. We also noticed that in the late 1990s and early 2000s, gram-negatives are making a comeback. The rates of gram-negative infections is increasing by a rate of 3 to 4% every year. And right now it's about 60 to 40%, 60 gram-positives, 40% gram-negatives. But as I said, every year we'll see a rise. The gram-negatives continues to rise. And then here's a chart with all the pathogens that are most commonly culprits of these infections in these patients. In terms of gram-negative bacteria, I should mention that the most common infections are patients' flora. So all the flora in your body basically can become pathogenic at some point if you're neutropenic. So most of the infections will be caused by your natural flora. And then for the gram-negatives, Pseudomonas is associated with the most serious infections. The most common gram-positive pathogen would be Staph epidermidis. It is not very aggressive, but it's known to cause over half of the infections in these patients. And obviously, the gram-positives are associated with the more severe infections or staph, specifically MRSA. Strep viridans is also very pathogenic and virulent in these populations, and enterococci. Polymicrobial infections are sort of infrequent, but they can occur. And for the fungi, the most commonly associated are Candida and Aspergillus. Among Candida, Candida albicans is the most prevalent. And then there's other agents like, if the patient is from an endemic area, you should always consider like endemic fungal infections like histo, blasto, cocci, and so on. So we're gonna, first question, just to warm up a little bit. We have a 42-year-old male who is currently undergoing treatment for AML. He presents to the ED with a fever from home, 39 degrees Celsius is an oral temperature, and then the rest of the vitals are completely unremarkable, and the physical exam is completely unremarkable. The ED team sends some blood work, and the ANC comes back to be less than 500. Actually, the leukocyte count is less than 500. So which of the following is the most appropriate initial step? Would you repeat the temperature measurement rectally to confirm this is a real fever? Or would you give granulocyte colony stimulating factor? Would you start them on IV cefepime empirically, or IV cefepime plus IV vancomycin, or oral ciprofloxacin? Or would you start a sort of a workup to know what's causing this infection, and in the meantime, you put him on droplet precautions and a special diet, strict hand washing for visitors, and then you do all of the workup? By a show of hands, who says number one, option one? What about number two? How about IV cefepime? How about IV cefepime plus vancomycin? Okay, oral cipro. And what about wait and see what's going on with this, droplet precautions and all the other precautions? All right. So, okay. So we have an answer here. We should do blood cultures first and then proceed with all of these. I think that's very valid. But we won't answer the question right now. We'll wait till the end. So if you want to wait for the answer, stay tuned. So the initial assessment. You have to perform a thorough H&P, and this is like, every time we give a talk, we do say we have to perform a thorough H&P. That's sort of a given. But in immune-compromised patients, we have to pay attention to what type of chemotherapy are they receiving, what's the timing of this chemotherapy. If they're using other immunosuppressive medications like steroids, for example, do they have a history of latent infections like TB, herpes virus, Hep B, HIV, any ill contacts, any unusual exposures? I remember I was doing research in the liver transplant team in the University of Miami, and they had a patient who had an alligator as a pet. So I would say that's an unusual exposure. Have they received blood in the past? And on physical exam, we should pay close attention to potentially infected sites, like as I said, the GI tract, the skin, and the lungs are the most commonly involved sites of infections. And if the patient has a vascular access, a port, or a central line, those sites should be assessed very carefully. We have to know that neutropenic patients don't typically show signs of inflammation as other patients. So it is very important to see that if the patient has some erythema, it could be an infection going on, even though we don't see any purulence. And then if they complain of urinary symptoms, and then the UA is not showing any WBCs or leukocyte esterase, it's because they are severely neutropenic, and those findings won't be as in other patients. And then, what specific test should we send? So this is actually from the guidelines, and I hope everyone gets a reference like labs. We should do CBC with differential. We should do BMP, hepatic function panel, serum lactate. At least 2 sets of blood cultures are recommended. Culture specimens from other sites if suspected, let's say that they have a skin infection, and then you can aspirate. If they have a swollen joint, and that could be like a septic arthritis, they should also be sent for testing. As I said, UA, our urine culture, is sort of a given. If they have respiratory symptoms, you can send a respiratory PCR panel, and this is the patients that those panels are most validated on, because definitely viral pathogens can be very severe and very aggressive in this population. The patient has neurologic symptoms, CSF also. And then for the risk assessment, so within 1 hour of the patient presenting to the hospital, you should give antibiotics. So you shouldn't spend too much time on the workup. I agree that if it's possible, you should get blood cultures first before giving antibiotics. That will, increase the yield of the result of the cultures. But within 1 hour, patient must receive antibiotics because these will improve mortality. And then this is sort of the first part of the assessment, but then we're going to stratify the risk of these patients, and we're going to use some scoring tools that are available and they're validated. Here, for example, we have the MASC index, which is the Multinational Association for Supportive Care in Cancer Risk Index. Basically, if for patients with a score greater or equal than 21, they are considered to be low risk. Anything lower than 21 is a high risk. And the CISNI score, it's also another tool. And within the CISNI score, you will be asked to assess for other scores, like the Eastern Cooperative Oncology Group Performance Status, which is right here. And also the degree of mucositis, if patients have mucositis, also have an impact on the certification of these patients. Also, where the patients develop this fever is also matters. So the Talcott's group classification address that issue. And in summary, any patient with a MASC score that is less than 21, or a CISNI score equal or greater than 3, or the presence of any of the following: severe sepsis, septic shock, hemodynamic instability, mucositis or severe mucositis, severe diarrhea, gastrointestinal symptoms, the presence of line infection, any new pulmonary infiltrate or hypoxemia, and any underlying, so comorbidities are really important in these patients. And we will see later how the number of comorbid conditions that the patient has significantly impacts the mortality in these patients. And COPD is a big one. So if a patient is COPD, that's a sort of an indication that this patient is high risk. There's some immunologics, like alemtuzumab, used within 2 months, that it stratifies the patients as high risk. And I know that we discussed labs. So in the guidelines, if a patient presents to the ED and they don't have any respiratory symptoms, the guidelines say do not do a chest X-ray. I would say that's a very controversial topic. If you are called by the ED team saying that a patient has neutropenia and has a fever, the first thing you're going to do is, where's the chest X-ray? So I think that's a topic of discussion, but it's part of the guidelines. And then in the second part, then if the patient is high risk, obviously you're going to admit the patient and do inpatient management. And if the patient is low risk, then there's other possibilities about outpatient management. I think that's very controversial at this point, and it would be a different topic for a different discussion. But now there's evidence actually that low risk patients can be managed as an outpatient. And as I said here, we have a graph from a paper, mortality, morbidity, and cost associated with febrile neutropenia in cancer patients. And we see basically one comorbidity doubles the risk of mortality. And then 3, 4, and even more than 4 increases the risk of mortality by more than 50% in these patients. So this is very important to do a thorough H&P and gather all the comorbidities that the patient may have. And as I said, depending on the severity, either these patients are stratified as low risk or high risk, the setting and the management in which the management will be provided will vary. So there are other patients who are low risk, but then should be admitted to the hospital for an inpatient management. And these patients are specifically, depending on what conditions brought the patient to the hospital. So if they came with a pre-syncope or syncope episode, if they have CHF, if they have arrhythmias or pericardial effusion, if they are tachypnic, hypoxemic, or hypercarbic, or if they have a cavitary lesion, if their renal function is worsening, if they have hematuria, oliguria, electrolyte derangements, if they have PO intolerance, they have severe GI symptoms like vomiting, diarrhea, ascites, GI bleeds, obviously sepsis, line infections, other components of the CBC that can be very abnormal in these patients. Very common scenario, specifically in hematologic malignancies, like severe thrombocytopenia, severe anemia, altered mental status, and so on. And then we have some scientific evidence that says that if patients do not have any respiratory symptoms, is it really worthy doing a chest X-ray? So this has been studied, and actually in the guidelines they say if the patient does not have respiratory symptoms, there's no role of a chest X-ray. I would say that's a hard thing to sell. And here in the literature we see that patients were in the outpatient setting developed febrile neutropenia, and they were assessed with chest X-rays or sinus X-rays. And basically, the rate of detection of pneumonia was less than 2%, and the rate of detection of sinusitis was less than 5%. If the patients do have respiratory symptoms and then they have an indication for an X-ray, that's a different topic. So in AML patients, like in this paper, they did have an indication for a chest X-ray, and then within 40 minutes of receiving the chest X-ray, they also did a low-dose CT, and then these findings changed management. The rate of detection of abnormalities in the plain films was 78%, and in the low-dose CT was 95%. And actually, over a quarter of these patients had a different management based on the CT finding. So I think that there's validated evidence for the role of CT evaluation in these patients. Here we have actually a paper from Stanford University. They were assessing patients with history of invasive fungal infections, and these are the typical patients that they will really benefit from a CT evaluation. So what about other biomarkers? I think for us, definitely these patients should have an ID consult. I think they are the ones who should be leading the workup and what to do, specifically if they have suspicious for severe infections or fungal infections. And then I know there's an upcoming lecture, I think in a couple of weeks, about invasive fungal infections. So they're going to discuss the role of these biomarkers in more detail. So biomarkers like the galactomannan that we know is a carbohydrate component of the cell wall of the aspergillus, the mold aspergillus, and is released during the growth of this mold. And then it can be used for the management of these patients. I don't think we should be sending this test because it can definitely be tricky if we don't send them in the appropriate patient or in the appropriate scenario. But it's definitely a tool that the ID physicians have to manage these patients. Here we have some evidence about a paper that basically said, should we guide our fungal therapy with the galactomannan results, or should we compare that to what the guidelines recommend? And then in this study, basically, it didn't show any difference. So it is not recommended that you basically use this. You should have an ID consult physician who knows how to interpret and what to expect once the results come back. And the same goes to the beta-D-glucan, which is a carbohydrate component of the walls of many fungal species. The only ones that are not that does not have the beta-D-glucan are Microalis and Cryptococcus. And also, another thing is that these tests can have a very high rate of false positives, and they cross-react with a lot of things that you wouldn't imagine, like some antibiotics. Even if a patient has dialysis, the cellulose that the dialysis filters use can cross-react with these patients and have increase the likelihood of false positive test. And then in these tests, they analyze the pool sensitivity of the beta-D-glucan, and it's like around 75, 77%. So it's actually not that great. So if it's indicated, it's very useful. If it's not, then you get in trouble because now what you're going to do with the test that you don't know how to interpret. And then here we have a chart of comparing beta-D-glucan and galactomannan. I know some people have troubles like differentiating these tests. You know, I think in the lecture of fungal infections, we'll have more details about it. We don't want to spend too much time here. And then there are other biomarkers like the procalcitonin, CRP, ESR, and basically the bottom line is IDSA does not recommend the use of any of these tests for the management of patients in terms of guiding antimicrobial use. There's too much controversy, so they're not part of any guidelines in the management of neutropenic fever. So now that we're going to dive into the management of these patients. Is vancomycin the answer for everything? So you have to initiate an empiric antibiotic therapy within 1 hour, and then we discussed that. And then even if you think that the patient is low risk, there's no discussion that you can provide these patients with IV antibiotics, and then if something changes and the setting of management will be in the outpatient, you can send them home with oral antibiotics, even if you gave IV antibiotics first. And what antibiotics should we use? So the most common monotherapy there's widely accepted and recommended in all guidelines is a monotherapy with an anti-pseudomonal beta-lactam agent. And cefepime is the agent of choice. And does anyone notice like anything particular about this dose of cefepime? It's a very high dose, and it's a dose that should be used in this patient. So when we give antibiotics, we're basically affecting the burden of the infection by providing antibiotics who will control sort of the source of infection, and then the immune system will take care of the rest. Here we don't have an immune system, we don't have neutrophils, so everything is expected to be resolved by the antibiotics, so that we give the highest tolerable dose, in this case 2 grams IV Q8 hours. Ceftazidime is an alternative. Here in our institution we use cefepime. Pseudoephedrine is also an alternative, and then anti-pseudomonal carbapenems, imipenem or meropenem. Vanco is not recommended as part of the initial regimen in these patients. There are some scenarios where Vanco definitely plays a role. If you are suspecting a line infection, if you are suspecting a skin or soft tissue infection, if the patient is hemodynamically unstable, or if the patient has history of multi-drug resistant organism. And there's controversy about pneumonia specifically. They said if the patient has a lung infiltrate, there's a role for vancomycin. I would say in 2010 that was proposed, and then it's even though it's in the guidelines, it's not very it's a common practice nowadays. There's something another topic for controversy, and maybe they will address that issue in the upcoming new guideline. Antifungal therapy is not recommended as part of the initial antibiotic regimen, but there's definitely a role if the fever persists for 4 to 7 days and we don't, and the patient is on broad spectrum antibacterial regimens, then there may be a role for broadening the spectrum and including antifungal therapy. And obviously, if the patient has history of MRSA, then early addition of vancomycin, linezolid, or daptomycin may play a role. I think we will need an IV consult in these cases. If a patient is known to have a VRE, then we should consider maybe linezolid or daptomycin. If ESBLs, obviously the carbapenems are the way to go, and so on. And then here are some of the most common antifungal medications that are typically used in these settings, like voriconazole is widely used antifungal. If you're suspecting candida, echinocandins also play a role. Obviously, there are some species that are resistant, but that's a different topic. And in terms of other therapeutic agents, so in the guidelines, IDSA does not recommend the use of colony-stimulating factors at all. However, in the most recent guidelines from the American Society of Cancer, the ASCO, they recommend these agents in certain scenarios. So some high-risk patients were expected to have very prolonged neutropenia of more than 10 days if they are very older than 75 years old, if they have an uncontrolled primary disease, invasive fungal infections, or if the fever, if they were in the hospital at the time of the fever. these agents that can definitely play a role. And some other special considerations, if the patient has a penicillin allergy, then cephalosporins, other alternatives include like ciprofloxacin plus clindamycin. We're covering here Pseudomonas, and aztreonam plus vancomycin is another alternative. And then what happens if a patient was managed in the outpatient, and then when is an appropriate time to bring these patients back to the hospital, or to the hospital in the first place? If they're low risk and they're being managed in the outpatient setting and they're receiving maybe oral therapy, but the fever does not goes away after 2-3 days, then it's an indication for bringing the patients to the hospital. If the fever does effervesce, but then they have a recurrence of the fever, or they have new signs or symptoms of infection, if they have PO intolerance, or an oral regimen does not cover the organism that we are suspecting, that's another indication. And obviously, if we had the patient in the hospital, we did some microbiology workup and then send the patient home, and then the susceptibilities come back and something else that the patient is receiving, that's another indication for bringing the patient back. And in terms of reassessment, so they typically recommend reassessment of the empiric therapy that we're giving every 2 days. So, but day 2 and 4 are critical. So if the patient is low risk and they have an unexplained fever, if they persist to be febrile, if they are clinically unstable, definitely inpatient management with IV antibiotics. If they effervesce and the cultures are negative, we may consider continuing oral medications or IV antibiotics. And here's where the controversy starts. Here in the guidelines, they say, okay, you should give treatment until they have proof of marrow recovery. If the ANC, so you should stop treatment once the ANC is greater than 500. So there's new evidence that says that that's not the case, but we will discuss that topic later on. And then other indications for like modifying the duration of the course or the regimen that is used. If the patient has an unexplained fever, if vancomycin or other coverage for gram-positive organisms is started early on, and then we don't have any microbiologic evidence of gram-positives or MRSA, then we should stop those antibiotics and de-escalate as soon as possible. And obviously, if the patient started on empiric treatment, but they become hemodynamically unstable, then we should broaden the coverage to resistant gram-negatives or resistant gram-positives, or even anaerobic bacteria or fungi. And then how long? This is what the guidelines say. So let me just jump here. So previously, we said that if a patient has febrile neutropenia and then we're treating the patients, we should wait until we see some evidence of marrow recovery. It wasn't until like 2017 when this Spanish group challenged these concepts, and they decided to do the first and at the time only open-label multi-center randomized trial, and they basically compared two groups, and the conclusion was that the empiric antibiotic therapy can be discontinued after 72 hours of absence of fever and clinical recovery, irrespectively of the neutrophil counts. I've been working in oncologic services where treating neutropenic patients every day, and this is the most current practice. So basically, we need an update on those guidelines because the information that is there is no longer the most commonly used practice. And then last year, a French group basically did a similar study that showed the same results. So we should be looking at and updating the guidelines and include these findings. Even the most recent edition of the Mandel, which is sort of like the Harrison for infectious diseases, they are basing their recommendations in these two papers. And then what happens with the low-risk patients? So for low-risk patients, if as I said, if they're in the ED, if you consider they're low risk, you can give either oral or IV empiric antibiotic therapy. But then, if you're deciding that this patient, can safely be discharged because you don't have any features of a high-risk patient, then the ciprofloxacin plus amoxicillin clavulanate is basically the regimen of choice. In terms of prophylaxis, so if the patient has neutropenic fever, we don't use monotherapy with quinolone. We may, or there's a common practice if a patient is expected to become neutropenic, to start them on prophylaxis with quinolones monotherapy. But remember, these patients they do not have a fever. They are expected to become neutropenic, and we're just giving some prophylaxis to avoid development of infection. If the patient has severe mucositis and we're going to give quinolone, then we should consider levofloxacin instead of ciprofloxacin, because we know the severe mucositis is associated with invasive strep viridans infections. And then the addition of gram-positive active agents to the quinolone in prophylaxis is not routinely recommended. And then the prophylaxis is not recommended if the duration of the neutropenia is going to be less than 7 days. So what about environmental precautions? So we know that for neutropenic patients, we typically use gowns, we use masks, we use cloth, we use like aggressive like hand washing, because these patients are really susceptible to different infections. But then early on, when the literature was when the guidelines were being developed for these patients, were some recommendations about the high efficiency particulate air filtration, and then most recent evidence says that these patients actually, or these filters actually, they don't make a difference in the management of these patients. If they're in the hospital, they don't have to be in a special room with these filters. And other common concepts like the neutropenic diet, actually there's a lot of robust evidence that says makes no difference between a regular hospital diet versus a neutropenic diet. And then we're going to touch bases about some syndromes that these patients can present with, like a cutaneous syndrome. So these patients are at risk of having, bacteria, fungi, viruses, parasites, and even non-infectious skin manifestations. So in the neutropenic host, disseminated fungal infections may be the initial recognizable characteristic of cutaneous lesions. So like here, for example, we see a picture of a disseminated candidiasis, and initially it just looks like a papule with some erythema, and then later on, when the ANC recovered, we saw that it became purulent, basically. So we can see that even though it is infected, we may not see the typical manifestations of a soft skin and soft tissue infection because of the lack of neutrophils. Let me see. CVC-related infections are very concerning in these patients. Suspect if the patient is septic shock, if it has endocarditis, if they have rapidly progressive bacterial infection, if there are local signs of infection, if the positive cultures remain positive without a source, or that is very important, if the fever develops when they use the catheter. That's a huge and important clue that there may be an ongoing infection. So the first thing we have to do is, I think, an ID consult, and then we will establish whether the catheter can be safely removed or if it's needed. In these cases, because it's the skin, we're maybe prone to think that the gram-positives are it's going to be the predominant pathogen, which is true, but also gram-negatives are very commonly involved in these cases. So line infections warrant anti-gram-negative coverage as well. And then empirical antifungal therapy, if we're thinking about a line infection, is not recommended by the guidelines. Obviously, there's some scenarios like TPN or other scenarios that can put patients at risk of developing invasive fungal infections, but that's other topic of discussion. And then the duration of the treatment will depend on what pathogen is associated, and also the fact that whether the patient had the catheter removed or not. For respiratory syndromes, basically every patient with respiratory symptoms who is neutropenic should be considered to have pneumonia until proven otherwise. Even if they don't have any radiographic evidence, pneumonia should be very high in the differential. And then these patients, you have to have a very accurate travel history because of the endemic mycosis. We should know that these patients commonly have other complications from chemotherapy, and if they are transplant patients, they can also have graft versus host disease, and that can definitely mimic a lot of things, including lung infiltrates. So we can also have atypical presentation of our organisms like pneumocystis, and then respiratory viruses in these populations can be very severe, and that is why it is so important to have a respiratory PCR panel. We can also have direct lung toxicity from the chemotherapeutic agents that these patients are exposed to. And also here we see an image with the halo sign, and this is typical for aspergillus, one of the most common radiographic pathognomonic signs for invasive aspergillosis and pulmonary aspergillosis. And some pneumonia pearls. So strep viridans been associated with ARDS in neutropenic patients, especially if they have a severe mucositis. So if a patient has severe mucositis and they develop ARDS, strep viridans should be high in the differential. It also matters when the pneumonia started. If it started at the beginning, if the patient came with respiratory symptoms and then we started them on the empiric regimen, that is one thing. But if the patient has a breakthrough pneumonia through the empiric coverage, then that opens the possibility that could this be a fungal infection? Could this be a more aggressive organism like an ESBL or a typical bacterial pathogen like Legionella? If the patient is at high risk for TB, then definitely TB is another possibility. And then neutropenic patients can also have, as I said, pneumocystis. They can have influenza, CMV, mycoplasma, other like less common or virulent pathogens in the normal host can definitely have different manifestations in the immune-compromised host. All cavitary lesions in the neutropenic patients should raise the possibility of bacterial infections, even fungal infections. Let's see, and also like we're going to move on to gastrointestinal syndromes. As I said, diarrhea in an immune-compromised host, can vary widely. It can be just side effect of the chemotherapeutic agents, but it can also be an infectious cause. And then Clostridioides and C. diff can be very severe in the immune-compromised host. Right now, if a patient has chronic diarrhea and norovirus has been involved in those cases, it's known to cause chronic diarrhea in immune-compromised host. Not so much in the neutropenic patient, but overall in the immune-compromised population. Oral candidiasis and esophagitis is also very concerning in these populations and should be treated if it's early identified. Viral esophagitis like CMV, HSV is also common. As I said, severe mucositis. We should think about anaerobic GPC because it's the typical oral flora are the most common organisms involved, and also severe mucositis is also associated with Pseudomonas. And then GI PCR panels, if the patient has these symptoms, can get a little tricky because they are so sensitive these days that we don't know if the patient is actually showing active infection with these pathogens, or they are just basically have an asymptomatic colonization and it happens to be picked up by the test. Other common complication in neutropenic patients is typhlitis or neutropenic enterocolitis. It is basically an overgrowth of an anaerobic bacteria in the colon, and that can present with very severe features to the point that we may think this patient has an acute abdomen, and they can even have hemorrhagic manifestations from the typhlitis. So for all patients with suspected abdominal infections, obviously bowel rest, IV fluids. Some even go as cases like severe typhlitis or neutropenic enterocolitis. These patients may need DPN for long periods of time until they recover from these conditions, and obviously broad spectrum antibiotics with anaerobic activity. Let's see. And then some neurologic syndromes, obviously the same neurologic, the same pathogens that can affect the normal host can also affect the immune-compromised host. So here we will pay attention to like Listeria monocytogenes that is known to cause meningitis in these patients, some other encapsulated bacteria like strep pneumo, or can be very aggressive and severe in these cases. And then other manifestations of like PRES, for example, can also be the culprit neurologic symptoms in neutropenic patients. It's being associated with neutropenia specifically. Here, next, we have some Mount Sinai protocols for the management of febrile neutropenia in BMT patients. I don't think we have much BMT patients here, but I thought it was good for you to know that these protocols are in place and then are readily available in some websites. So I can, later on send an email with the protocols, and basically they will tell you step by step what to do in these cases. And I think for us, this is a little more relevant. So patients with hematologic malignancies, non-transplant hematologic malignancies, and then the prophylaxis that they recommend, including some antiviral medications, some bacterial prophylaxis, and antifungal medications. We don't typically deal with these medications too much, and we may not be a little familiar with these antifungal medications like posaconazole, for example, which is now first-line for fungal prophylaxis in AML, for example. But I think it's good that you know that these guidelines exist, and then just for you to be able to find them if you need them. And here we have, again, sort of the same guidelines. So some questions. I think for here would be go with IV cefepime. The blood cultures issue, definitely if you can get the blood cultures first, that's the ideal scenario. But basically the question was, what medication should you consider first? And this patient did not have any high-risk features or colonization with MRSA or any indications for gram-positive coverage. And then we also learned that there's no role for granulocyte colonizing and colony-stimulating factors. And oral ciprofloxacin, I think, is too soon to make that decision. And then we also know that we should avoid, measuring the temperature rectally in these patients. Another question, a patient has an ANC below 500 for 2 weeks after induction chemotherapy for AML. What do you think these patients are at increased risk for? Remember that the patient is neutropenic. So as I said, the most common pathogens in these patients are the normal flora. So E. coli and gastrointestinal tract pathogens are basically the most common pathogens that are going to be involved in these cases. These patients are not at greater risk for varicella or influenza, and then crypto neoformans, it doesn't play a role here. And then what is the most likely cause of neutropenic enterocolitis that develop after receipt of cytotoxic therapy or AML? Again, mixed anaerobic and aerobic bacteria. So I think that would be all. And thank you. Don't give Imodium to your neutropenic patients. You will end up working at 7-Eleven. Do you have any questions? Oh, okay.
Any questions?
Yeah, we do precautions, special precautions, with also droplet precautions for the patients. So you have to put everything, with a clinical picture. If you're suspecting that the patient may have a pathogen that is detected by this test, definitely you should send it. It is very sensitive about the specificity. It depends on what pathogen are we talking about. And we are also, remember that we're measuring parasites, viral infections, and viral pathogens and bacterial pathogens, and everything is sort of